is the vitamin D that is decreased. So at my age and this activity, with all full activity, this vitamin D3 can come decrease. So you can think for the epidemic. Right? So I did more investigations for supporting causes, because the main cause is like to rule out the causes. The other investigations are normal. So TSS slightly increased. So I did my bone mineral density. So these are the two reports. One male is 33 and others is mine report 45 years. So mine T-score is, so how to read the bone mineral density report when we do bone mineral density. So you can see we assess by T-score or Z-score. So my T-score is minus 1. If it is in between -1 or +1, it is normal. If it is -1 to -2.5, there is osteopenia. If it is lesser than -2.5, means there is osteoporosis. So in other report, the T-score is -2.3. It's like osteoporosis. This is the same date we did the bone mineral density, and the patient is 33-year-old, but he has chronic renal failure, due to which he has such a decreased T-score. He has osteoporosis like that. So he has bone pain and all. So we did his bone mineral density. So now, so this is the fracture tool assessment. It shows the last for further 10 years whether you are prone for fracture or not. So if I have to come to the diagnosis, we have to assess history. So history is very important. There is pain, back pain, hip pain, wrist pain. These are the common finding in which there is a osteopenia like that and osteoporosis. Physical, we have to do all the physical examination and the investigation like D3, calcium level, to rule out many things, hyperthyroidism, hyperparathyroidism, and like renal failure. So we have to do all the other investigations. And BMD scan. So reasons are primary causes, which is age related, postmenopausal. Secondary causes are there. Patient is having thyrotoxicosis, hyperparathyroidism, and renal diseases, etc. Mainly, a patient is on steroids, anti-epileptics, and chemotherapy. Most important thing for me is proton pump inhibitor. I am on proton pump inhibitor daily, taking proton pump inhibitor since 15 years. So this may be the reason for my these values. So after and one of the most common cause is after decreased mobility, when patient is immobile, he or she is a bedridden. That time there is a faster bone osteoporosis is there. One more thing has come up. The patient with low body mass index and who do high exercise, strenuous exercise, he has more chances of osteoporosis. Dr. Vivek is here. Okay. So that is the thing we should know when we have low body mass index and we are doing strenuous exercise. So other causes are smoking, alcohol, early menopause, these are the causes when there is a chances of osteoporosis. So, solution treatments, if we discuss, these are the solution: lifestyle changes, be active, weight bearing exercise is more having more advantages than not weight bearing exercise like swimming and cycling. They are better for cardiac and cardio exercises, but for osteoporosis, walking, brisk walking, running, and these exercises are important for to prevent osteoporosis. So supplementation, there are calcium, vitamin D3, anti-resorptive and anabolic and biphosphonate teriparatides. These are the anabolic some treatment. So this is the flow chart when how we should assess the patient and when we should give treatment to the patient and when to not. So what are the therapeutic options for the osteoporosis? We can choose anti-resorptive drugs like biphosphonates, calcitonin, ERT or HRT, and raloxifene, which is the selective estrogen receptor modulator, and simulators of bone formations, parathyroid hormones, mixed mechanism, active vitamin D metabolites. Strontium renylate is the mineral which is used nowadays, which is exactly like calcium. So it is also used, right? So we have to use, all women who are risk for osteoporosis can use calcium and vitamin D. Some facts I have go through. These facts are: calcium supplement increase 1% bone density in first year of its use, and thereafter there is no increase in bone density if you use calcium. The other disadvantages of calcium are there are chances of gastritis, constipation, and stones, right? So we have to think before giving long-standing calcium. You have to give breaks, or you have to give it, prescribe it wisely. Vitamin D supplements do not improve bone density except D3 level is lesser than 30 nanomoles per liter. In my case, it is helpful. So I am taking it. It should be given for like 12 weeks. Give a break, then again give. Right? In osteoporosis, calcium with anti-resorptive drug do not have effect on treatment efficacy. Means it is, if you are giving the biphosphonates and all drugs, so calcium will not support it by the review article, but we should give if there is a deficiency calcium and vitamin D if it is deficient, right? So we can use these drugs. Time is less. ERT, this is estrogen replacement therapy. Yes. So we can use this biphosphonates. Like we have to give once a week, half an hour before food. Same drug with this drug. If there is a more reflux, you have to. Patient is having reflux disease. You have to give it carefully. Ask the patient to sit for half an hour at least, because there is a chances of esophageal congestion and further consequences. So this aloxifene you have to give once a day. We can give, this is the drug we have to give once in a 6 months, costing nasal calcitonin nasal spray is better than subcutaneous, so it is proven better. Teriparatide, 30 days pain is there, 20 microgram per day you can give. So major challenges are for the spine osteoporosis are fracture, stenosis, progressive spinal deformity, and for us concern for performing spine intervention. Neeraj Jain sir is doing multiple vertebroplasty. He can explain better than us. Right, sir? Take home message: asymptomatic spine osteoporosis is main challenge. Diagnosis may be clinical or can be confirmed by investigation. There are multiple treatment options, but should be used carefully. And before doing any spine intervention, think for osteoporotic spine. Thank you. Thank you for kind listening.